Start Salve Live.
Yeah. Good morning, all the faculties and all the delegates on this online platform of IAP Delhi, in which we have been doing master classes in various specialties of pediatrics. And right now we are doing it on pediatric cardiology. We had very excellent sessions in this online series by Dr. Neeraj Agarwal and others, where the baseline of all the heart disease is already being set. And today we have a very, very important topic of acyanotic congenital heart disease taken by a doyen of pediatric cardiology. I think the first pediatric cardiologist which I met when I started my neonatal practice in Delhi, Dr. Radhakrishnan. I remember when we used to take babies from Gangaram Hospital to Escorts Hospital to get their echoes done and then bring them back if there is no structural serious heart disease and leave them there if they require surgery. So that is long time back. We have been doing it for many, many years. And now we are fortunate that we have very established pediatric cardiology services under the guidance of Dr. Neeraj Agarwal and Dr. Mridul Agarwal and Dr. Raja Joshi. So that is why we have somehow not meeting Dr. Radhakrishnan that often. But yes, we are going to a very interesting session. I welcome our CIP EP member, Dr. Manish Mehta, and we also welcome Dr. G.S. Narang sir on this platform of Online Delhi. And before I hand over to Dr. Mridul and Dr. Neeraj for the proceedings, I also welcome Dr. Harish Pemde. And happy Father's Day to all of us. Many of us are fathers here. So Mother's Day and Women's Day are celebrated with a lot of vigor and enthusiasm, but let us also celebrate Father's Day. So let's hand over to Dr. Neeraj Agarwal for the proceedings. Dr. Neeraj sir.
So thank you, Pankaj. Thank you, Pankaj sir. This has been excellent series till now. And today we all know we are fortunate enough to have Dr. Radha sir. As you say, sir, we all have been his students at some other stages. We all in the room, in the panel has been benefited by his work. He has been doing genuinely ethical work for years and years, and we all are inspired by his understanding of pediatric cardiology and his ethical work. That's why he's a father figure to all of us. Me, Mridul and Jay, we all are three have been his students at one of the stages, and we welcome Dr. Radha sir. Thank you, sir, for allowing us to meet you at least on online platform and get your guidance whenever we need it. Even today, Dr. Pankaj sir, we call him sometimes to get his guidance, to get his views. So this is about Dr. Radha sir. Thank you, sir. And then we have two chairpersons, respected chairpersons. Dr. Gulsharan sir, I know him from SGRD when I used to visit his places. Still today, I go occasionally to his place and started the pediatric cardiology clinic in Amritsar. SGRD Medical College. He's the HOD of SGRD Medical College. The extreme interest in specialties of pediatrics. So he has been trying to develop super specialty in pediatrics in Amritsar, and he has been pioneer to start a pediatric cardiac program, and we have been fortunate enough to be his part for last 3 years, I think. And he has extreme interest in thalassemia and neurology. He has been Central IIP board member in 2024, nodal medical specialist for thalassemia. He has been AFP-AHA's executive member also from Punjab. He has more than 65 publications, index journals. Thank you, Dr. Gulsharan Narang sir. Thank you, sir, for having your presence here and give your guidance. Thank you very much.
Thank you, sir.
Dr. Manish sir is a EB member, our Central IIP 2025. He is currently working in Synergy Neonatal Center, Ahmedabad. And I am pass out of Gujarat. I'm a member of alumni of Surat, GMCS Surat. So I know the ethics being done in Gujarat. They are excellent people. All Gujaratis are excellent people. And Dr. Manish Mehta, he is very good in intensive care, in neutral care. So we welcome his expertise for this session. Dr. Manish Mehta, thank you for joining us today. Thank you.
Thank you. Thank you.
And now I would request Dr. Gulsharan Narang sir and Dr. Manish Mehta sir to say a few words about this today's program.
Hello, good morning to all. Sir, thanks for making me a part of this very good program. It's a very good program for the young cardiologists. I met Dr. Radha long back in 22 years back. My daughter was his patient and presently she is done his MBBS also. Thank you for making me a part of this program.
Thank you, sir. Thank you and welcome, sir. Thank you. Dr. Manish Mehta, few words
Morning,
from
everyone. Yeah. So, first of all, I congratulate IIP Delhi for very good initiation because congenital heart disease and cardiac things are usually overlooked in our conferences. There is a very small session always in the conference about the congenital heart disease. And in the era of this focus, point of care ultrasound, echo, the importance of clinical bedside diagnosis of congenital heart disease has become very less. Yeah, previously we used to apply statue in the different area of the heart and used to put a probable diagnosis of whether it is BSD or it is PDA. But in nowadays, whenever someone puts testo and there is murmur, immediately referred to the pediatric cardiologist. So it's a very good initiative to have this topic on this session. And I congratulate once again IIP Delhi and thank them for making me this person for this important session. I wish them all the best for their future sessions. Back to Dr. Neeraj, sir.
Thank you. Dr. Meena, sir, few words from you, sir. Dr. Meena, sir, Sham Meena, sir.
Hello, very good morning to all, and very much we are Delhi IIP thankful for the Dr. Neeraj. They making the wonderful program of the on our past session. Really, we getting the lot of the positive feedback from our participant. So thank you, sir, for making such a wonderful program.
Thank you, sir. Dr. Prendra, sir, few words and then we can start the session.
Yes. Thank you very much, IIP Delhi, and I must congratulate IIP Delhi for this wonderful program. As Pankaj remembered meeting Dr. Radhakrishnan, I also remember meeting him when he was training at AIMS, late 90s. I don't know whether he remembers me or not, but Anita Saxena Madam and Dr. Kothari were there. They made this Department of Pediatric Cardiology, and of course, Dr. Radhakrishnan also contributed there, and I'm very, very happy that he is contributing profusely in the field of pediatric cardiology, and I'm eager to listen to him today. Thank you.
Thank you. Sir, can we start the session now? Radha, sir?
Please.
Yes, thank you very much for all the wonderful words spoken about me. I remember it was 1996 when I joined Escort Heart Institute from Sanjay Gandhi Postgraduate Institute. And then after that, the first neonatologist, the first pediatrician I came in touch with was Pankaj Garg, Saluja, and Dr. Neelam Clare. In fact, they were responsible for the continuation of the program at Escort Heart Institute. All the patients, whenever they had suspicion of congenital heart disease, were referred to us. So that whole program, I think, has had a huge contribution from these three trios. And of course, over a period of time, they developed their own program, which is wonderful at Gangaram Hospital. And thank you very much, Pankaj. Saluja is not here. You know, Satish Saluja was almost my contemporary in Maulana Azad Medical College, just a year junior to me. And we used to meet frequently and were good friends right from 1975-76 onwards. So today I spoke to Neeraj and I asked him, who are the audiences? What do you want me to speak on? I'm sure, and he told me that I had this in mind, the bedside diagnosis, and he agreed with me, not those high-flown stuffs like the balloon dilatation, stenting, etc. I don't think the pediatricians would be very much interested. Of course, they should know about it so that they could refer at the appropriate time. So I'll be talking about the bedside diagnosis of acyanotic congenital heart disease. I don't know how many of you are aware of two stalwarts in the field of pediatric cardiology who introduced us to this subject. Remember that we were all trained adult cardiologists, but these two stalwarts, the two icons in the northern part of the country, unfortunately, they are no more with us, was Professor Savitri Srivastav and Professor Rajendra Tandon, who actually started the department at All India Institute of Medical Sciences and have all been his and her student. And they were the one who introduced us to the auscultatory skills. Of course, one can never match their skills. We always thought that it was the stethoscope which used to do the trick, but we later realized that it is not the stethoscope, it was their own skill. And you won't believe there was a time when they would refer patients for heart surgery, especially the simple ones, the acyanotic ones, which I'm going to talk about, AST, VST, PDAs, only by clinical auscultation, X-ray and ECG. They didn't have echo with us. It is only when we joined the program that the echo machine was introduced. And there was a time when Professor Tandon, when he would make a clinical diagnosis, we would make a different echo diagnosis. He would send it back to us and said, no, this diagnosis of yours by echo is wrong. Please do it again and see, because this is my clinical diagnosis. That is the level of confidence they had. At All India Institute, in the OPD, we used to sweat in these summer months because there was no air conditioning, etc. There were only two rooms which had soundproofing and air conditioning, and that was Professor Tandon's and Dr. Savitri Srivastava's room. So we were lucky in that way that we used to go inside their room, the context or pretext of learning pediatric cardiology, and we used to sit comfortably in that AC room. So this is a brief story of how we evolved. And I want to tell the current lot of students that please don't forget this art of auscultation and making a clinical diagnosis. And this does not come in a day. It comes out of years and years of practice and correlation with what you see. Now you have the advantage of having the echo machine with you. So correlation can be wonderful. Your clinical diagnosis and what the echo tells you. Remember that it is not the stethoscope. You might buy any amount of Littman. I know Dr. Tandon and Dr. Savitri Srivastava used to have a Hewlett Packard stethoscope. And we thought that is the reason why they are able to do such a good job. But no, please, it is not the stethoscope. It is just years and years and years of practice which hones those skills and to make you a clinical diagnosis, or accurate clinical diagnosis. You might say that it is not necessary nowadays with the availability of these wonderful imaging modalities, but I think there is still a lot of place for correct interpretation of clinical findings, X-ray and ECG. And of course, X-ray and ECG have a definite place in the diagnosis of congenital heart disease, which cannot be replaced by any other modality. Thank you. I just move on to the topic now. So remember that a lot of these pictures that you see today, the slides that you see today, was given to me by Professor Tandon, and he specifically told me, please distribute it amongst the students. That is what he always used to tell us. So he defined congenital heart disease in a very simple form. He said it is a structural heart disease which is present from birth. The incidence we all know is about 10 to 20 per thousand live births. 10 out of 1,000 congenital heart diseases are actually bicuspid aortic valve. So it is one of the commonest forms of congenital heart disease. If you count the number of babies who are born premature, the numbers or the incidence would actually increase in number. So the 5 questions that we have to answer at the bedside is, does the child have heart disease at all? Because there are so many mimics that you are aware of or will become aware of over a period of time. Is it congenital heart disease? What group does it belong to? What is the specific diagnosis and what is the severity? It looks very simple, but at each step, one might actually get into trouble and not be able to proceed further. A simple question, is it congenital heart disease? Looks very simple, but then I'll come to it and show you that there are specific criteria for even such a simple question. So Alexander Nadas, who's considered one of the fathers of congenital heart disease, developed a criteria for the presence of heart disease. And as usual, like many criteria, he divided them into major and minor criteria. The major criteria included a systolic murmur of grade 3 or more. So whenever you have a murmur which is more than grade 3, he or she is likely to have some structural heart disease. Diastolic murmurs, of course, always makes it a structural heart disease. You cannot have diastolic murmurs which are not related to congenital heart disease or related to structural heart disease. Cyanosis, of course, is a mimic. You can have cyanosis due to respiratory failure. You can have peripheral cyanosis, etc. So, but if it is because of heart disease, it becomes a major criteria. Congestive heart failure is also a mimic. You can have congestive heart failure because of various non-structural heart diseases, but it has been classified as a major criteria if you're sure that it is related to heart problem. And then, of course, you have minor criterias, abnormal blood pressure, abnormal second heart sound. This can only come out of auscultatory skill, because to you it might appear as if the second heart sound is normal. For others, it might appear abnormal, again, depending upon your auscultatory skill. Systolic murmur, you have all experiences which is less than grade 3. Nowadays, almost all of them have echoes. Even a grade 1 murmur is subjected to an echo. But statistically speaking, if it is a grade 3 murmur, less than grade 3 murmur, you're unlikely to find a structural heart disease. Abnormal ECG has been included because ECG is something which varies with age. I'll just give you a simple example. A transposition of great vessel, a complex disease like TGA in a newborn period will have a similar echo to that of a normal newborn because of the evolving cardiovascular physiology. Of course, if you see a 1 year or a 2-year-old child with a transposition, obviously you cannot confuse it with a normal ECG. Abnormal X-ray has been included as a minor criteria because there are so many mimics of abnormal X-rays. A typical one which we frequently used to confuse was an enlarged thymus and was referred to us for with a diagnosis of cardiomegaly. And anyway, they used to have an echo because of the pressure given to us by the pediatrician to actually be very sure that there is no heart disease. Next question, is it congenital heart disease? That is usually very clear if you make your diagnosis before 2 or 3 years of age. But beyond that, one has to be very sure, because there are other forms of heart disease, acquired heart diseases, especially in a country like ours, like rheumatic heart disease, which can be a mimic of congenital heart disease. And of course, as the age increases, it is sometimes very difficult to say that it is congenital heart disease. And therefore, that is why we have these criteria. Then we have if you have a parasternal murmur, it is said that the chances of having congenital heart disease are more. And typically, parasternal murmurs are not very common in acquired heart diseases. The only exception is probably subaortic stenosis, but that's also a congenital heart disease. Aortic stenosis, which can occur at a later age, which is not related to congenital heart disease. Of course, if you have cyanosis, as we already discussed, abnormal BP, and then if you have associated extracardiac anomalies, just as in fetal echo, we say that if somebody picks up extracardiac anomalies, one should always refer them to a fetal echo guide, because the chances of having congenital heart diseases becomes very high. And so even after birth, if you notice extracardiac anomaly, we should be extra cautious. These are very simple forms of extracardiac anomalies. Now, of course, this whole thing, genetics in cardiology, has evolved into a super specialty. And of course, Gangaram Hospital has a wonderful department of genetics led by Dr. Ratnapuri, who frequently helps us in solving riddles and puzzles of these things, which are so difficult for us sometimes. So there are certain associations of abnormalities of forearm, syndactyly, polydactyly, Downs, of course, which we are all aware of, arachnodactyly, Turner's syndrome, rubella syndrome. These are very simple and common forms of congenital heart disease. And then, of course, there are more complex varieties. The third question, what group does the child belong to? I'll talk to you about in the next slide. I'll come to it. And what is the specific diagnosis and what is the severity? This is where we want to classify congenital heart disease into these three broad categories. Why is it important? Because each category has its own natural history, may have its own unique finding. The follow-up of each of these categories are very different. Let me give you an example. If you close a PDA today, all you need to do is follow up of about 3 or 4 years, and then you can let the child go, provided, of course, there was no pulmonary hypertension. But a cyanotic heart disease, even after treating, requires a lifelong follow-up. A child with pulmonary hypertension requires continuous follow-up. Obstructive lesions require, so each one of them has its unique natural history, unique patterns of follow-up, and therefore this classification has stood the test of time for decades onwards. And when we teach the students, and also when we follow it, we follow this pattern because it is still very, very important for us to classify them. So today I'm going to talk about only the left to right shunt, which we typically call acyanotic congenital heart disease, and obstructive lesions. These are the two varieties which come under the category of acyanotic congenital heart disease. Cyanotic heart diseases, of course, are a different subcategory. Next question, what is the specific diagnosis? And this is where we get our auscultatory scale. Typically, left to right shunts present with frequent respiratory infection. It is very difficult to define frequent. When you are sitting in the OPD, the mothers will come and tell you, "Isko to har baar zukham lagi rehti hai." That is not a frequent respiratory tract infection. A frequent respiratory tract infection to be a serious issues are the ones which require admission, repeated admission. There are some criteria giving 3 or 4 times a year or so, whatever it is you want to follow. And of course, the child suddenly becomes very sick due to frequent respiratory infection, not just because the nose is running and that becomes a respiratory infection. Increased sweating, we all know, is a non-specific sign. You can sweat because of various reasons. The worst thing that happens is when the relatives come to us and we tell them, look, this child is sweating because of ventricular septal defect and heart failure. And after the surgical correction or after the correction, the parents come back to you and tell you, Doctor Sahab, jiska to abhi bhi pasina chhutta hai. You said that it is because of heart disease. So aren't you worried about it? So it is very important to make it clear that it is a non-specific sign. But yes, it is a sign of probably more severe heart disease, a sign of heart failure, increased respiratory effort, etc. Left to right shunts typically do not have cyanosis, especially early in the natural history. Of course, they can get converted into a cyanotic heart disease once they develop the Eisenmenger physiology, which is actually a negative this thing. It should not happen. You don't see cyanosis because of previous left to right shunt in the Western population, but we continue to see cyanotic heart disease due to Eisenmenger physiology in this country. Tendency for congestive heart failure, we pointed out it's a non-specific sign. You can have heart failure even without heart disease. Precordial bulge can also be present because of frequent respiratory infection, which has nothing to do with heart disease. Cardiomegaly can occur due to various reasons. Hyperkinetic precordium can also occur due to various reasons. And then, of course, we actually come to the real situation that if a shunt and flow murmurs are present, then, of course, it becomes a definite finding. X-ray chest will show cardiac enlargement and so-called increased vascularity, which we will show you some pictures, one or two pictures of that. So let's talk about the specific heart diseases. We, of course, come to the atrial septal defect, which is one of the commonest forms of congenital heart disease in the adult population. In children, of course, it still remains ventricular septal defect. So again, I keep on emphasizing these are skills which you develop by repeatedly auscultating, whether you like it or not. Go and listen to the child again and again. Only then you can come to the level of Professor Tandon's and Professor Savitri Srivastava, which we regret we still have not come even after 30 years of practice of congenital heart disease. It's not possible to reach that level. But yes, we do attempt, we still keep on auscultating. So in atrial septal defect, you have an accentuated first heart sound, which is because of the tricuspid component of the second heart sound. This is something which is not very well appreciated and generally ignored. But what cannot be ignored is the wide split fixed second sound. Whether you can appreciate a loud P2 or not, you should be able to appreciate the wide split second out sound, because that is the only way you can make a diagnosis of atrial septal defect, or let me say a communication at the atrial level. So if you find that, it is the most specific way of diagnosis of atrial septal defect. So even if you have previously diagnosed atrial septal defect by imaging, etc., please go back and listen to the patient and try to elicit this finding of a fixed split second sound. It is said also that the second component of the second heart sound, that is the pulmonary component, is almost always loud, and it has clinical implications, which I will come to it later. And then you can have an inconstant ejection clicks. X means ejection click. What are the murmurs that you hear in atrial septal defect? You don't hear the murmur at the level of the shunt, because they are low pressure communication between the right atrium and left atrium. So no murmur can be produced at that level. What you do hear murmur are actually flow murmurs, flow across the pulmonary valve. So you will hear an ejection murmur at the pulmonary area, the second left intercostal space, and you hear a tricuspid flow murmur, that is a diastolic murmur along the left lower sternal border close to the sternum. I mean, you can elicit all these signs if you take time, and it is very gratifying actually if you can elicit these signs. pulmonary ejection murmur is, of course, very obvious. You'll hear it at the second left intercostal space. It is actually the tricuspid flow murmur, which is difficult to elicit. But in children, if you have time to listen to them over a period of time, you would be able to appreciate this murmur also. In adults, it is almost impossible to elicit this sign. What does it mean? It means that it is a significant shunt across the atrial septum. Clinically, that is what it means, that if you have a flow murmur, a diastolic flow murmur, it always indicates a significant shunt. So again, it helps you in making a clinical diagnosis. This is an X-ray of an atrial septal defect. You see cardiomegaly. There are two things that you see here is the dilated right atrium. I hope my arrow is able to show this, and a dilated pulmonary trunk. That is the main pulmonary artery. Besides, of course, an increased plethora of the lung, which is not very well appreciated in this X-ray because it takes time for all these signs to develop. But what you do appreciate is the dilated right atrium and the dilated pulmonary artery. You can have dilated pulmonary arteries in other shunt lesions like VST and PDA, but you will not have dilated right atrium in the other two shunts. So one can be very sure that it is an atrial septal defect. An ECG typically shows a right axis deviation and a right bundle branch block. I hope you can appreciate this ECG. But in the same clinical finding of a fixed split second sound, the flow murmur, the ejection murmur, if you have a left axis deviation, then you can make a clinical diagnosis of an ostium primum atrial septal defect very confidently. So they have the same clinical finding, the same X-ray, but a different ECG, which clinches the diagnosis of an ostium primum atrial septal defect. Let's look at ventricular septal defect. Typically, again, S1, that is the first sound, is masked by the murmur because they are pansystolic murmurs. It starts with S1 and ends with S2. Again, something which is difficult to appreciate. S2 can also be masked by the murmur. So all you hear is a loud murmur starting from S1, ending at S2. But if you go slightly up into the left second intercostal space, you will be able to appreciate a wide split second heart sound. But remember that this widely split second heart sound is mobile. That is, in expiration, it becomes a single sound, and in inspiration, the two split. Unlike atrial septal defect, where it remains split both in expiration and inspiration. And then, of course, you can hear a third heart sound, typically in the apex, which you might have frequently heard in patients of congestive heart failure due to any reason, like, for example, dilated cardiomyopathy, etc. So that also you can appreciate. It has a connotation that if you hear only a third heart sound, then it is likely to be a small shunt. So a pansystolic murmur with S3 at the apex means it's a ventricular septal defect with a small shunt. What are the murmurs that you hear? Of course, you hear this loud, unforgettable pansystolic murmur at the mid-sternal border. That is the pansystolic murmur. And you also hear flow murmurs. Flow murmurs are very important for clinical diagnosis of severity of the disease. I'll come to it later on. So there is one a flow murmur, which is at the pulmonary area. Unfortunately, you don't hear that because it is masked by this loud pansystolic murmur. But as you move on to the apex, you might hear either an S3 or a delayed diastolic rumble. Very similar, but not the same as that of a mitral stenosis murmur. So, if you can appreciate it by auscultating at the apex with the bell of the stethoscope, then of course you can be confident that clinically speaking, it's a large shunt. I'll come to the assessment of the severity later on. Here is an X-ray. Here you can appreciate the plethora of the lungs. You can see these end-on vessels here. There is a definition for this also. Here you can see these small circles here. These are all end-on vessels and they should be extending into the periphery of the lung. You can appreciate it in the left side also. What you also appreciate is that the pulmonary artery segment is prominent. There is cardiomegaly, but there is no right atrial dilatation. In fact, you have left atrial dilatation in a patient of ventricular septal defect. So the triad of findings is plethora, cardiomegaly, and left atrial dilatation. Whereas in atrial septal defect, it is right atrial dilatation, plethora, and cardiomegaly. We now come to the ECG. ECG will show, depending on the severity of the shunt and the pulmonary artery pressure, typically it shows left ventricular hypertrophy, not right ventricular hypertrophy, but left ventricular hypertrophy. And as the pulmonary arterial hypertension increases, it starts showing various other phenomena like Katz-Watzel phenomena, etc. I'm not going into that detail because it is a separate topic by itself. But what you do appreciate is the very high voltages in V4, V5, V6, and also in 1 and AVL, which actually translates into left ventricular hypertrophy. Some people call it hypertrophy, some may call it enlargement, because hypertrophy is something which is different from enlargement. Here in VST, it indicates left ventricular enlargement, whereas in aortic stenosis, etc., it indicates left ventricular hypertrophy. Patent ductus arteriosus, there is no other dramatic murmurs that you see in your practice of congenital heart disease than patent ductus arteriosus. It is so distinctive and such a localized murmur. You hear it only in the infraclavicular region. Patent ductus arteriosus murmur doesn't radiate anywhere, unlike collateral murmurs, etc., which you can hear all over the chest. Patent ductus arteriosus, which produces what is known as a continuous machinery murmur, is so classical that you cannot miss the diagnosis. Now, what about the splitting of the second sound? There is nothing unusual about the first heart sound. The second heart sound splitting again goes with the severity of the disease. We'll be coming to that. It can be normally split, it can be narrowly split, and it can be paradoxically split. Paradoxical splitting is one of the most difficult clinical signs to elicit at the bedside. And you have to be very sure. And even we at this level of expertise are sometimes not able to make out. Of course, I have seen Dr. Professor Tandon make paradoxical splitting second heart sound so easy to elicit that you wonder what is wrong with you. Anyway, fortunately, now we have other modalities of diagnosis. But if you can elicit it, it is one of the most happiest day for you. And you go and tell everybody your colleagues say, look, I elicited a paradoxical splitting of the second heart sound. We used to do it as students and feel proud about it. So in PDA, you have, as I said, a continuous machinery murmur. Why do you call a machinery? It is actually a mimic of a machine working in a factory, and you can actually hear what are known as eddy currents. Besides the murmur, you hear a lot of noise along with the murmur. We call it eddy sounds, EDDY sounds. And the best part or the most important part is that PDA murmurs are always localized to the infraclavicular region. So you should not confuse it with other reasons for continuous murmur. And then you have, just like for VST, you have the delayed diastolic murmurs in the mitral area, again indicating the severity of the disease. And you have aortic ejection murmurs also. Remember that some of them are phonocardiographic findings, but you should be aware of it. And this ejection murmur is typically drowned in the continuous murmur that you hear. But phonocardiographically, one can elicit some of these signs, which becomes difficult to elicit by clinical methods. This is a PDA. Again, you notice left atrial dilatation. You see the splaying of the trachea. You see the pulmonary artery segment very prominent, but you don't see left atrial enlargement. And of course, there is evidence of plethora to an experienced eye. It is not as dramatic as you saw in a ventricular septal defect patient, which I showed you previously. But you do see, if you look at it carefully, some end-on vessels, especially on the right side. We then come to the second group of acyanotic heart disease, is an obstructive lesions. What are the clinical signs? Typically, you don't have cardiac enlargement of cyanosis. Cardiac enlargement occurs only if the patient goes into heart failure due to neglected obstructive lesion. No precordial bulge typically. You feel a forceful heaving cardiac impulse, which is more dramatic for aortic stenosis. For pulmonary stenosis, since the right ventricle is behind the sternum, it is difficult to elicit this sign of a forceful heaving cardiac impulse. But of course, in aortic stenosis, you can dramatically elicit this sign, and you can be immediately sure that for some reason, the left ventricle is hypertrophy. You hear thrills, systolic thrills, which you can sometimes hear in ventricular septal defect also, especially the small ones. But this systolic thrill that you feel has also a different connotation that it immediately brackets it into a severe form of obstruction. Then we have ejection murmurs. I'll come to it. There is a delayed corresponding S2. You have to understand this physiology, only then you would be able to appreciate. Whenever there is an obstruction across a ventricle, the left ventricular ejection time or the right ventricular ejection time, whichever area the obstruction is, gets delayed. It gets prolonged. So the left ventricle or the right ventricle is going to eject for a longer time. When that happens, what happens is that the corresponding second heart sound, whether it is pulmonary or aortic, gets delayed, and you hear different forms of splitting of the second sound. Even if you're not able to appreciate these sorts of splitting of the second sound, but at least you should know the physiology of obstructive lesion. What does it do? It prolongs the ejection time of the corresponding ventricle. And that is what is responsible for the manifestations of the second heart sound behavior. ECG will, of course, show ventricular hypertrophy. X-ray typically can be normal, even in the most severe forms of obstructive lesions like aortic stenosis or pulmonary stenosis. As soon as the child or the patient goes into heart failure, then cardiomegaly starts appearing. And of course, clinically, the child will manifest with congestive heart failure. Here is an pulmonary stenosis murmur. So concentrate on the second sound, S2. Here, P2 will be delayed and it will become slightly softer, widely split with normal movement. So the second heart sound will be widely split depending on the severity, and movements will be normal. It will not be fixed. But what is more important with all these things is that you hear a click and what is known as the inconstant ejection click. What is inconstant ejection click? As compared to that of aortic stenosis, the click will keep on moving. It will appear in expiration, fuse in inspiration, and that is heard just before the onset of the murmur. So the ejection clicks are heard before the onset of the murmurs. And of course, with right ventricular failure, you can hear sometimes S3, you can also hear S4. These are very difficult signs to elicit, again, because the right ventricle is just behind the sternum. So what is more important is ejection systolic murmur. Here that you see, I've written ESM, a widely split, a delayed and soft pulmonary component of the second heart sound, and of course, an inconstant ejection click, typically best heard in the pulmonary area. So these are the findings of a pulmonary stenosis. An ECG, of course, depending on the severity, will show right axis deviation and a right ventricular hypertrophy. So these are constant signs. If you have right ventricular hypertrophy, of course, it points to a significantly obstructed pulmonary valve. In aortic stenosis, again, you hear an ejection murmur. A2 will be delayed, and therefore, as the severity increases, it initially is normal, then it becomes single, and then it becomes paradoxical, something very similar to PDA. Why does this happen? Again, I'm revising it, that initially it is normal, it indicates mild disease, then it fuses with each other, indicating moderate disease, and then it becomes paradoxical. That is, the A2 comes after the P2. That is again because the left ventricular ejection time is prolonged. And therefore, the aortic component, my left finger, starts moving towards the pulmonary component, and then it overtakes it. And then, of course, here the ejection click is constant. You will keep on hearing it and it will be widely heard. Unlike the pulmonary ejection click, aortic ejection click can be heard in the second right intercostal space, in the left parasternal area, and it can be heard in the apex also. So if you hear an ejection click in the apex, it is nothing but an aortic ejection click. And that is the graphical demonstration. What is an ejection systolic murmur as compared to a pan-systolic murmur? An ejection systolic murmur, there will always be a delay from the onset of the first heart sound to that of the onset of the murmur. And there is this ejection click that you see here. And it will always end before the component of from where the murmur arises. That is, if it is arising from the aortic area, then it has to end before A2. But if it ends, yes, it has to end before the A2 because you cannot prolong an ejection click beyond the aortic component of the second sound. So you have to understand this physiology. There is no other way to understand how to explain these murmurs. So you have to spend time. I know you have so many other topics to learn in pediatrics while you're training, but do spend some time, even if you have not developed your auscultatory skills, which develops over a period of time, at least you should be able to spend some time understanding the physiology. I don't know why it's not moving. Okay, here it is. Here again, you see left ventricular forces instead of right ventricular forces. You see left ventricular forces here. You can see that in V5 and V6 and lead 2, lead 3, they're all T waves. What you also notice is that the ST segment is depressed. The T waves are inverted here. That points to the severity of the disease.
So there is a question there.
Yeah.
ECG, someone is asking ECG finding of ventricular hypertrophy either due to ventricular pressure or volume overload will be same.
Yes, I that's why I said I've not come into so much of detail about ECG. You notice, let me go back. You notice you don't see if it is a volume overloaded left ventricle, you don't see these T wave inversions like this. In fact, you see tall T waves. T waves are tall and upright. That indicates, so with left ventricular hypertrophy, if you have tall T waves which are upright, it indicates volume overload. And if it is inverted and depressed, it indicates pressure overload. That one can discuss when we talk about ECGs specifically. But thank you for asking me this. Is that what you want to know?
Yes, that was a question posted on Q&A.
Okay, okay. So there is something called volume overloaded left ventricular hypertrophy, and there is something called pressure overloaded left ventricular hypertrophy. I showed you the ECG of PDA or ventricular septal defect. They also had these tall T waves, but they have tall QRS complex. But here, there you had tall T waves which were upright, and here you have depressed T waves with a downsloping ST segment. So that is the difference.
So can we, for the students, can we say shunt lesions are better seen on X-rays and obstructive lesions are better seen on ECG because most of obstructive lesions would not have cardiomegaly in the
Yes,
initial phases.
that's true. That's true. Agree with you.
Okay, sir. Thank you, sir.
Coarctation of aorta is another form of left ventricular pressure overload. You don't appreciate any precordial murmur here. Typically, if you are very keen and if you are smart enough, you can elicit a continuous murmur at the back, a rumbling murmur, which has two reasons. It is not typically because of the coarctation itself, but because of the extensive collateralization that develops between the upper segment and lower segment. In fact, you can sometimes see those arteries which move along the intercostal space, uh, and you can appreciate that. You might have a late ejection murmur, which is not very specific murmur, because the precordium typically in coarctation is silent, but there are other findings, of course, femoral not palpable, a very prominent suprasternal pulsations, etc., etc. This femoral artery pulsation is something which every student has to develop a habit of. Please don't miss this finding of any child, of any uh, even a grown-up child or an adolescent whom you see in practice when they come to you. First, your hand should be going on to the femorals because that could be the only clue to the diagnosis. There have been innumerable instances, both in adult and pediatric practice, where patients have been diagnosed as dilated cardiomyopathy, especially in the newborn and pediatric group, where people have failed to palpate the femoral pulsation and they move along with all sort of diagnosis. So palpation of the femoral artery is the most important clue to that of coarctation of aorta. Of course, you have other lesions also, but we'll not go into it, aortoarteritis, etc., etc. So murmur is not a very important feature of coarctation of aorta. You hear these continuous murmurs and late ejection murmurs only when the coarctation child grows up. But in your group of patients that you see on a daily practice, it is the femoral pulsation. So don't please ever miss to palpate the femoral vessel whenever a child comes to you with suspected heart disease, because that could be the only sign of coarctation of aorta. Again, an X-ray which is non-specific. What you do notice is if you follow this lower margin of the ribs here, you see these indentations here, which I hope I am able to show you by the arrow. These indentations are again not seen in the pediatric population usually. They are seen with long-standing collateral flow, which is seen along the intercostal arteries along the lower margin of the ribs. Typically not appreciated. And you have the so-called reverse three signs, etc., etc. But if you compare it with femoral artery pulsation, they all pale in front of that single important sign to diagnose coarctation of aorta. There is this so-called Eisenmenger physiology, which is actually a movement from a patient who was cyanotic to acyanotic to a cyanotic. You don't see them in the Western population, but you still continue to see this physiology. And there are remarkable findings. What you see is again, there is no cardiomegaly. What the child who had a large shunt and a big heart now comes to you with a normal sized heart because all the shunt has disappeared and it has now started reversing. There is no parasternal heave except for AST, but the single most important finding in these patients is a palpable second heart sound. That is, in the second left intercostal space, if you can elicit this sign, you know that you are dealing with a patient of severe pulmonary hypertension. So, no murmur, a palpable second heart sound, and of course, additional things that start developing later on is a pulmonary regurgitation murmur and an ejection click, which is constant, although it is not arising from the aortic area, it is arising from the pulmonary area, but yet now with pulmonary hypertension, an inconstant ejection click becomes a constant ejection click. So again, difficult sign to elicit, but what you must be able to say is that the patient will be cyanotic, there will be no cardiomegaly, there will be a palpable second heart sound, and of course later on you'll start developing pulmonary regurgitation, tricuspid regurgitation, etc. So acyanotic congenital heart disease becomes a cyanotic congenital heart disease. It is a neglected group of heart disease which develops over a period of time when it is not treated. So, Eisenmenger syndrome, I have just discussed with you. This is an X-ray of an Eisenmenger syndrome. This is a more classic X-ray, huge pulmonary artery and no cardiomegaly. Look at this. You can't see more dramatic X-rays of Eisenmenger. And how do they die suddenly? Because the pulmonary artery ruptures, and that's the end of the story. And you clearly see that there is no cardiac enlargement. And finally, what is the severity of the heart disease? I've been discussing with you the severity of the heart disease as I'm discussing. So now I'll quickly go through this. It determines the line of management, medical treatment, surgical treatment, etc. So severity of the left to right shunt in general is assessed by heart size, symptoms, the splitting of the S2P2, flow murmurs, and degree and type of pulmonary hypertension. Now we are moving on to a more difficult area of discussion. A severity of an obstructive lesion is assessed by ventricular hypertrophy and size. You assess it by the splitting of the second sound, presence of S3, S4, systolic murmurs, the BP, the ECG, and of course, I should not be talking about this, the Doppler gradient. We have moved on to Doppler, which we are not, this is not the topic of discussion today. So this is what I've been talking about. So when you have a large shunt, you will always have cardiomegaly, whether it is AST, VST, or a PDA. The second heart sound will be uniquely split. They will be called what is known as the shunt murmur, which I had discussed with you. And then, of course, you have flow murmurs. So you have murmur coming out from the shunt, and you have a murmur which is related to flow. So let's see this. In AST, the P2 will, S2 will always be fixed. Whether there is PAH or not PAH, the P2 will be loud. So wide split second sound and a loud P2, irrespective of a degree of shunt. So in ASD, the use of second heart sound is not very useful in assessing the severity of the pulmonary artery pressure. In VST, as we told you, pansystolic murmurs with a normally split second sound. Then you have a group of patients who have large flow, no pulmonary hypertension. They will have a P2 which is variably split and which is slightly loud. Then you have a large flow with pulmonary hypertension, and there the P2 will become more loud, and these are things which you will be able to appreciate again by repeated auscultation. And finally, you have the Eisenmenger physiology. PD again, I spoke to you about the paradoxical splitting of the second sound. You have the continuous murmur, and then the movement of the second sound. If it is small, it will be normally split. If it is moderate, it will become single second sound, and then paradoxically split if it is a large shunt. Again, very difficult signs to elicit, especially the paradoxical split, but at least you can appreciate the murmur, the continuous murmur, which is almost always dramatic. So I'll skip through this. We can always discuss it in subsequent sessions about how you classify a pulmonary hypertension into hyperkinetic and obstructive. I'm not going into the details of this. In obstructive lesion, it is the length of the murmur which determines the severity of the disease. Besides the ejection clicks, which is constant, inconstant, longer and louder the ejection murmur, the more severe the disease is. So this is something basic that you have to remember. Longer and louder ejection murmur, till of course ventricular failure occurs. Once the heart fails, the murmurs gets truncated. So in aortic stenosis, as I told you before, A2 becomes delayed and finally becomes paradoxically split. And in PS, what happens? The A2, P2 keeps on, because normally you have A2, my left hand, and P2, there is always some delay. And as pulmonary stenosis progresses, the A2 remains like it is, and the P2 starts moving forward. Remember that you can clinically appreciate this thing only when there is this so-called wide split, only when there is a significant obstruction. So in general, for obstructive lesions, the more severe the obstruction, the louder and longer is the murmur with a delayed peaking. Once the heart failure starts occurring, then the murmur gets truncated. Okay, and then of course you hear S4, which is because of ventricular hypertrophy, and you can hear S3, it is because of heart failure. So to summarize, ladies and gentlemen, clinical diagnosis of congenital heart disease is a very fascinating subject. We have all gone through that phase, not us as much as Professor Tandon and Professor Savitri Srivastav, when they didn't have the privilege of having a stethoscope at the echo at the bedside. So you can imagine how much skills they have honed in, they had honed in themselves to make such diagnosis. It's a very algorithmic approach if you follow a specific pattern. And now we can have instant confirmation of your clinical findings due to availability of imaging at the bedside. And it is very unfortunate to say that it has become a dying art. I have to admit for myself also, I don't spend that much of time in clinical diagnosis as much we would have spent about a couple of decades earlier, because we have the availability of the echo at the bedside, or even not even echo, the other imaging modality. In fact, we don't even look at the X-ray nowadays. We have become that complacent that we don't look at the ECG, we don't look at the X-ray, we auscultate if we want to, if we have the inclination, just listen to the patient and say, okay, jaake echo kara lo, and everything is available. But then it's an art. One should not leave this practice as much as you can. That's all I can say in this. Thank you very much for your listening.
Thank you, sir, for the nice session. And Dr. Gulshan Narang sir is there, is the head of department in SGRD. We can ask him how do their students are doing nowadays with the clinical art. Do they see the X-ray, ECG? Sir, your opinion on this part?
Sir, Dr. Radha has very rightly said, nowadays with the upcoming of the high-end machines, even if there is a little doubt of murmur or something, they directly send the patient for echo. that dying clinical sense needs to be again incorporated in our PGs.
Yes, I think so. And the
Yes, sir.
onus of responsibility lies on us
Yes,
as
sir.
teachers.
So actually, ICUs and everywhere the echo machine is lying inside the ICUs nowadays.
Yes, yes,
Earlier, it was not available. That was one of the reasons to make a clinical diagnosis first.
yes. It's lying everywhere now.
Everywhere, हाँ, correct.
ओपीडी में भी पड़ा रहता है.
थोड़ी सी प्रॉब्लम है, इको लगाओ.
हाँ, हाँ.
Dr. Manish, what do you think,
Yes, yes.
Gujarat? What is happening about focus? Things have happened lately in Gujarat. What do you think about this system? About
Yeah, so
clinical
sir,
after
now,
focus?
yeah, nowadays I have seen a few ICUs, including our KEM ICU. They have echo machine in the ICU, and the registrar doesn't have statho on his shoulder. Around the echo machine, and on each and every patient, he'll put the echo probe and he'll decide how much fluid is to be given, how this patient's heart is behaving. So, use of stethoscope is reducing in the practice. If I say there is nothing wrong, if you find some chest signs, immediately go for X-ray. If you find some murmur, immediately go for echo. So that is what the things are happening, which is not good for clinician perspective. So in private practice, as sir has said, hardly anyone looks at the X-ray or ECG, or they'll try to see whether pulmonary plethora or oligemic lung fields are there, or what are findings in ECG or PR interval or long QT interval. All these things, no one look at all these things. Even rather, people don't advise ECG at all these days. I would say like this, unless there is obvious
Yes,
arrhythmia.
very right.
So yeah,
And
so
this
these are
whole
the things in
thing
private practice.
has been perpetuated by editorials and this which comes from the West. Hang your stethoscope. It's a useless piece of instrument and all these things. And the youngsters also read it and say that. But the question is, you have to ask them, will you be able to diagnose atrial fibrillation without actually looking at the ECG? So I mean, these are certain things. Will you be able to diagnose increased blood flow without looking at the X-ray? These are all basic clinical, which one should not forget. Anyway,
Yes,
we
sir.
are all
Yes, sir,
growing
definitely, sir.
old now.
So, yeah, so the gadgets should be like add on to your clinical knowledge rather than you should replace your clinical skills. So that is
That
the
will
main issue.
happen only if, as teachers, you tell them you will not touch the eco machine unless you write down the auscultatory findings. This is what Professor Tandon and Professor Savitri Srivastava used to tell us. तुम eco machine छुओगे नहीं जब तक तुम अपना clinical findings नहीं लिखोगे.
So there's a question
Even
in the
sir,
chat
what
box.
Yes.
There's a
yeah,
question
sir,
in the
even
chat
whatever
box.
session you have taken, no one takes in our conferences also. Like these type of session I have heard after years probably. So such a basic things about murmur, like intensity of the murmur, which area of the chest murmur will be there, what type of murmur, so everything. So it's great, sir. It's really great.
Dr. Mridul, there's one more question in the question box.
Yeah, there's a book recommendation for the clinical method for in pediatric cardiology.
Sorry.
There's a question about asking book you can read about
Lot
pediatric.
of ambient noise. Needed.
So they're asking
Yes,
that
sir.
what
There
which
is
book
a
to
lot of
refer to?
noise. There is a lot of noise coming up. Dr. Pankaj, sir.
Which book to refer to? That is the
Oh,
question.
oh, there are lots of books, but one which I would recommend for clinical this thing, Professor Tandon had come up with a handbook. I mean, Neeraj, you must be knowing about it. A handbook of clinical
Yes.
practice, clinical cardiology or pediatric cardiology. I don't remember the
Yes,
head.
sir. It's about a 100-page book. 100-page
Yes.
book. Yes. We all have read it. And it's not
Beautiful.
available nowadays. It's not available nowadays.
Oh.
But in every unit, there is a soft copy going on. The
Yes.
copy.
Yes.
So we'll share the copy, sir. We'll share the copy with the delegates.
Sir, one more question I have.
Yeah.
Sir, nowadays if someone completes his PG and thinks to do some fellowship or DM in pediatric cardiology, like what do you see the future of pediatric cardiology? Like is he going to do only echo in future, or is he have some more exposure in intervention and everything?
Oh, yes, it has a tremendous future. Neeraj Agarwal would agree with me. I mean, yes, clinical auscultatory skills and all will over a period of time, I feel, will die down unless we ourselves encourage them. But then eco is here to stay till you are alive or I am alive. There is no question about it. And interventional skills are increasing. Even now, we have excellent interventional skills amongst the pediatric cardiologists. And the list of lesions where we can intervene without surgery is also increasing. Unfortunately, surgical number of surgeons who would like to practice only pediatric cardiac surgery is not increasing as much as pediatric cardiologist numbers are increasing.
Yes, totally
Probably
agree.
a lot to do with remunerations and all, not much money available
The
as
number you have dialed is currently.
Yes,
other
sir.
practice.
Yes, that is true, sir. We also are observing this part. And for Manish, if I may say with permission of Radha sir, we are still lacking in diagnosis. Interventions are not needed the R. There are multiple centers. You can have a particular center in a particular state that this center will do the interventions, but diagnosis is the need of the R. If you can make a diagnosis center separately and intervention centers
The number you
dedicated
have
centers
dialed is
separately,
currently busy.
that may be
Please try
a good idea actually. So I don't know, but I personally feel we're still lacking in diagnostic modalities rather than interventional modalities for now.
So, can I ask a question here? So, Dr. Radha sir, you did everything clinically till the last of your presentation, even severity, management, everything was clinical based. But now, as you are rightly saying that echo is available everywhere. So, do you feel that in your practice, it has ever happened that you made some observations clinically and then you have to change your observations or management
Oh,
after
yes,
echoes were done?
many times. Many times.
So,
That will occur. I told you in the beginning that there were times when Professor Tandon used to send back the patients after an echo and tell us, oh, your finding is echo findings are wrong. I'm not wrong. I am clinically right. I don't think we will ever reach that level of expertise because also we have seen, unlike Professor Tandon and all, they have not seen the rapidly evolving technology of eco, but we have been witness to both. And we, of course, realize the shortcomings of clinical auscultation. Especially, you guys are always in the ICU dealing with newborn, neonates, and all these children, where clinical auscultation has its own limitations. And that is why nowadays you have in the ICU, you have a ready availability of echo. Uh, but then, as I said, one should not forget the skills. Dr. Tendon's time, there were really no neonatal ICU, so to speak. It was never so advanced. And so in the neonatal period, there is definite limitation. And especially for people like you who are sitting in the ICU always. So echo is a very, very important tool for clarifying certain issues.
and about the future of pediatric cardiology after echo, some more sophisticated gadgets will come, which will even replace echo as far as functional understanding of these disorders is concerned, or echo
I,
is the last word in this field.
I don't see anything new coming in imaging. Of course, there are certain new things like three-dimensional reconstructions of heart diseases, of structural heart. That is what will be the future. For us, also understanding of the anatomy and also for the surgical understanding for intervention. We already have 3D MRI, 3D CT, and all being developed in order for a better understanding from both interventional as well as surgical, and of course, in general understanding. And in future, I think this is what is going to be taught to the students also.
Thank you so much. Over to Dr. Neeraj.
So I think we can conclude the session. It's already time, and we'll try to reconnect, sir, in some more sessions, coming sessions. Thank you, sir. Thank you for joining us, for imparting your wisdom to us today. And we can conclude the session
Over
today.
to Dr. Sham for vote of thanks. Dr. Sham.
Thanks to our chairperson, Dr. Narang sir and Manish sir. I hope they are the continuing support to Delhi IP in subsequent academic activities. And I'm very thankful to our program coordinator, Dr. Jaya and Dr. Mardul. And very much thankful to Dr. Neeraj. You did the wonderful job and constituted the wonderful program, because we are the continuous getting the lot of the feedback from our participants, and still some of the participants are requesting for the registers in the subsequent activities. And after a long time, today I have get the opportunity to heard such a wonderful basic such like the basic approach for the cardiac disease from the dyne of the pediatric cardiology. Thanks a lot, sir, Dr. Radhakrishnan sir, for the making the such a difficult topic to in simpler way. I hope our audience definitely get the benefit. And sir, for your kind information, these all activities we are the sharing on the YouTube in the recording section subsequently.
Okay.
So everyone can approach to this session or subsequent session by the YouTube Delhi IAP.
Thank you. Thank you.
Thank you so much. And we'll see you next time, same time. No, next time there is no session because we are 22nd June. We have the lipid conference in Lee
Yes, sir.
Meridian.
Yes.
So 22nd, there will not be any session. We will be seeing you again on 29th of
29th.
June.
Yes.
Okay.
Okay. Till
Thank
then,
you.
enjoy yourself and again, happy
Bye,
Father's Day to
Pankaj.
all. Right. Bye,
Bye,
sir.
Pankaj.
Bye, sir. Bye.
Say
Thank
hi
you so
to
much.
say hi
Yeah, I will
to
do that.
Saluja also.
Definitely. Saluja and Neelam, both I will say.
Thank you.
Right. Thank you. Thank you.